Toxoplasma gondii, Babesia, Cristosporidium parvum, and Isospora
Yes, have we
belli.
covered them all?
Yes, we covered them in the last class.
Okay. Have we covered all the flagellates?
Yes.
Can you name me the flagellates?
The hemoflagellates, we have the Leishmania and Trypanosoma.
Have we covered them?
Yes.
And the ones which are in the intestinal, the oral, and the genitalia? Giardia, lamblia, and trichomonas. Have we covered?
Yes.
So, in my opinion, we have finished the unit. So, for those of you who are, he has given us the sporozoans, let's just go through them quickly just to make sure we're on the same page. He has told us about Plasmodium, and under Plasmodium, we covered malaria. Then we talked about Toxoplasmosis gondii. I don't know if we have, or if we've covered them. We have Babesia. We have Cryptosporidium parvum, and we have Isospora belli. And then we covered the medications. So we had talked about this Isospora belli. It causes, it's mostly, we said you'll find it in the file as a cause of HIV, diarrhea, and we treat with trimethoprim, sulfamethoxazole. Trimethoprim, sulfamethoxazole, we covered it in malaria. Babesiosis, you're also going to cover this in vet pharmacology. It's actually a tick-borne infection. It's mild, self-limiting. The medications are antibiotics like clindamycin, erythromycin. And then we have quinine, which we've covered in malaria. We have Cryptosporidium parvum, again in immunosuppression, maybe malnutrition, HIV. It's a cause of diarrhea. And we said it causes diarrhea by sodium malabsorption. Yeah. And increase of intestinal permeability. The medications, we have the aminoglycoside paromomycin, we have azithromycin, and we have nitazoxanide, which we've covered all these drugs before. If you haven't, you want us to cover, tell me we cover again. Nitazoxanide, just to remind you, is just a broad spectrum drug similar to metronidazole. And action is actually interruption of enzymes. It's an enzyme, it interrupts the pyruvate ferredoxin oxireductase enzyme, which is an enzyme important for anaerobic energy metabolism. Okay, so if you wish to cover anything again, kindly let me know. Let me now check about the hemoflagellates. Hemo meaning they are in blood. We talked about leishmania. So I'm just trying to find out if what you know, what you don't know. Leishmania. So leishmania as a hemoflagellate. The second hemoflagellate is trypanosomiasis or sleeping sickness. What is this leishmaniasis? We had said that we have 20 different species. It's an insect vector host and it has a mammal host. Okay, and you should be able to name which host depending on which examiner you can get. They can ask you any question. So it's good to know exactly what about this condition. So know which is the insect host and which one is the and then which is the mammalian host. Okay, for the purposes of depending on whoever comes, and also it's a good thing to know continuation from your microbiology. I think specifically about it, we talked about the sandfly, female sandfly, phlebotomus argentifus, okay, and then mammalian host. Of us, we are concerned with the human, and we had covered the two stages, the one in the insect, the sandfly, and the one in the human. And we talked about the amastigot stage, I hope you can remember that. We divided it into four: cutaneous, mucocutaneous, diffuse, and visceral forms. We said the cutaneous are self-limiting, the mucocutaneous and the diffuse and visceral forms cannot resolve without therapy. Then we said the visceral is caused by Leishmania donovani, and it is fatal unless treated, also known as Calazar. Here is cutaneous. We talked about the cutaneous one, Leishmaniasis, mucocutaneous because it's at the junction of the skin and the mucous membrane. And this one is the disseminated Leishmaniasis, cutaneous. This one is a visceral type. Then we talked about the medications, sodium stibogluconate. We talked about miltefosine, which is an effective oral drug for visceral leishmaniasis. And you were to look at a few new drugs, talked about amphotericin B, and we talked about the prevention of the disease and the post-Calazar leishmaniasis. So, I'm inviting any questions. I'm moving fast because I think I just want to review and see where we reached or where we didn't reach. So those are hemoflagellates. So leishmaniasis. Let me put up the slides for. And you had asked for the notes, which I did not send. I can send today, but understand my notes, because they're not the class notes, they are PowerPoints. They are summarized notes. So if you still want the notes, I'll still send them. However, you cannot rely upon them for detailed answers. Now, we have this second hemoflagellate, sleeping sickness. Let me attach it. And we said that these trypanosomes, there are several types of trypanosomes. We have the trypanosome brucei, trypanosome brucei gabiensis, and then the trypanosome brucei rhodiensis. Yes, and then we have the trypanosome cruzi, which we said causes the American sleeping sickness. So there are all these subtypes. Then we said that the trypanosome brucei gabiensis and the trypanosome brucei rhodiensis need two hosts. They need two hosts to complete the cycle. Yeah, so we have the human host and the insect host, which is the tsetsefly, or what we are calling the Glossina species in microbiology. And we said we will look at this life cycle. And we said that the the trypanosome brucei gabiensis causes West African sleeping sickness, or West African trypanosomiasis. If you want to remember, Gambia in West Africa. Okay, Rhodesia causes the T. brucei rhodiensis causes the East African form of sleeping sickness, or trypanosomiasis. So the T. brucei gabiensis has long-term progression. And has got later CNS. It has later CNS symptoms or involvement, whereby the other one, the T. brucei rhodiensis, has rapid early CNS involvement and cardiac failure. Okay. The American disease, or Chagas disease, we said causes cardiomyopathy, megacolon, as well as death. Okay. Now, the symptoms, of course, will depend on the type of species that you have you have acquired. Okay. Now the parasite, it's extracellular. Okay. We said there's early disease, late disease where you have CNS involvement, and that determines the type of species determines the kind of medication that you will use. So I think we covered this. Correct me if I'm wrong. So for standard early stage disease, we said pentamidine for T. brucei gabriensis, suramine for T. brucei rubiensis. In late stage disease, we said they're not effective and you have to add melarsoprol. And of course, these drugs are parenteral for long periods of time. We said eflornithine is the only alternative for late stage disease for T. brucei gabriensis. And I think we covered all these drugs individually. Okay, so let me know which one you want to repeat. The drug, there is pentamidine. We have covered, and we've covered it. Okay, suramine, eflornithine, melarsoprol. In detail, So these are summaries of the notes. When it comes to Chagas disease or the American trypanosomiasis, we said we use two drugs, nifutimox, and we use benzimidazole. Okay, and this disease again, the insect is different. We have these Ludwig bugs. And we said cardiomyopathy, megacolon occurs. Nifutimox, benzimidazole are used to suppress the parasitemia. Of course, they are long-term medications. There is nifutimox. So we've covered all this. So do you still require the notes? I don't think so. I can send them because by now you should be having very good short notes that you wrote from a textbook, but I can send email. Then we had said that you will look at some of the new medications available for this condition. Did you look? Yes or no? There is no answer.
No, we didn't.
Why? Okay, let me look for you. Let me try and open one or two things. So I want to open one or two articles and open. Only 1 minute. So I want to open like the current therapies for leishmaniasis. If there are any new treatments for leishmaniasis. So I'll open one article. I can send it to you, or you can also Google it. Let me try and put this out. Are you able to see my my article on current and emerging therapies for the treatment of leishmaniasis?
Yes, we're able to.
Okay, this article, the name of the scientific journal is there. You can see it is an Indian magazine or from Asia, and it was published in 2024, so it's pretty current. Let us see. It is open access, an open access article. So the article, if you can see, it just introduces leishmaniasis as a neglected disease, and it is true it's neglected. And remember, we had said the medications for leishmania. We had the sodium stibogluconate IV. So this article, let me quickly skim through the article. It talks about the pentavalent antimonials, which have been the preferred treatment for worldwide for many years. But there is a case of resistance. Remember, I told you there is resistance, and because of resistance, you have to use 2 or more drugs. For example, you can add amphotericin B with sodium stibogluconate or pentamidine for it. So, and we said that these drugs had some side effects. Okay, they have some side effects. So now this is an expert opinion. It says, for almost 8 decades, treatment for all forms of leishmaniasis was solely dependent on the stibogluconate compounds, despite several drawbacks like long treatment regimens, cardiotoxicity, and drug resistance. In the past 20 years, 3 drugs with anti-leishmanial activity were developed for human disease. So we need new anti-leishmanial drugs. Okay, so know the 3 drugs I've told you: the sodium stibogluconate, the amphotericin B, and the miltefosine. Now we look at the new drugs that they talk about. The article talks about 3 main forms of leishmania: visceral, cutaneous, and percutaneous. And the important one we said is the visceral one, also known as Calazar. And then you need to remember how to classify, the cutaneous leishmaniasis, slow healing skin sores. They can be self-limiting. You don't have to treat them. Then we have the mucocutaneous. I think I've showed you all the pictures. I gave you the names of all the parasites last time. And then we have the visceral one, which is what we're calling Calazar. And then we have the post-Calazar dermal leishmaniasis. So this article just tells you that this post-Calazar or the PKDL, it occurs following apparent recovery from visceral leishmaniasis. But what happens is after 1 to 2 years, the parasite can remain dormant after treatment, and then it becomes active again to cause these post-Calazar lesions that we said resemble they resemble like some HIV rash. I've showed you all these pictures. So you look at this article. So currently available medications are few. The limitations. So existing therapies, we have leishmania. Remember the pentavalent antimonial compounds. The drawbacks. The article just says the same thing I was been saying. We have the cutaneous one. And remember, we had divided our parasites into New World and Old World. New World meaning they are leishmania from America, New World, and Old World meaning that they're found in places like Africa. Also, we had divided them based on what they cause. For example, visceral leishmania is caused by Leishmania donovani. Mucocutaneous leishmania can be caused by Leishmania brasiliensis. Cutaneous leishmania can be caused by Leishmania tropica, ethiopica, Leishmania major, Leishmania brasiliensis, Leishmania mexicanus, and all that. So this article just is a summary of exactly what you have said. And it just shows that cutaneous leishmania in Peru, Brazil, and Guatemala caused by Leishmania brasiliensis. So it is exactly what I was telling you. So miltefosine is recommended to treat cutaneous leishmaniasis caused by Leishmania guianensis. So notice the names, guianensis, Leishmania panamensis. It just shows that these ones are in Guyana, in South America, in Panama, Panamaniensis. Okay, those are just sub species of this Leishmania. So miltefosine, yeah, it's effective for cutaneous leishmaniasis. So what else do we say about miltefosine? We said it is oral drug. We said the mode of action. Last time we said it can alter lipid metabolism. Okay, lipid metabolism in the parasite and affect cell signaling in the parasite. So just have a look at this article and the notes. So miltefosine is an effective, safe drug for cutaneous leishmaniasis. Okay, we have amphotericin B. When do we add amphotericin B? It can be used with or without sodium stibogluconate or pentamidine in drug-resistant disease. We have covered liposomal amphotericin B before in antifungal infections. Okay. So here a similar study reported a better cure rate than stibogluconate compounds, okay, when you combine it together. So additional dose on the 10th day of liposomal amphotericin B gave successful treatment. Okay? So it's good for the resistant forms of the disease. So the current recommendation is to administer amphotericin B at a dose of 1.5 milligrams per kilogram per day for more than 5 days to achieve satisfactory results. Likewise, a weekly dose of 7 milligrams per kg of pentamidine for treating L. guianensis showed improved effectiveness. So just know that we add amphotericin B to treat with or without pentamidine gives better efficacy. Okay. Then they mention itraconazole here in this article has some promising anti-leishmanial activity. Okay. This article talks about old world leishmania. And we said old world leishmania is the one that is not in America. By Leishmania major, Leishmania tropica. So don't be confused by this name. You just know we're talking about leishmaniasis. This article, I was trying to divide for you Leishmania in the old world, Leishmania in the new world. In the new world is in the Americas. As you can see, what they list here is Mexicana, Guyana, Panama, Amazoniensis, Peruviana from Peruvia, Venezuelensis from Venezuela. So I think because of slight differences in the parasite, depending on the country, they have divided them into these subspecies. So if you have old world leishmania, it just means it's occurring outside the Americas. New world is occurring in the Americas. That's all it means. So in the old world leishmania, by major and tropica, where Africa falls, most lesions heal over time. Remember we said cutaneous leishmaniasis is self-limiting. We can use the sodium stibogluconate. We can use also methyl benzothium chloride can be applied to the lesions. They're talking about cryo and thermotherapy can be used as local treatment. Remember, it is local. Why? Because it is cutaneous. Okay, so you can use cryotherapy, thermotherapy. That is cryo meaning cold therapy, ice therapy. Thermotherapy means you alter the temperature on local skin lesions. So you can mention that as one of the treatments. In the New World, leishmaniasis, why New World? It is in the Americas. We have this mucocutaneous leishmaniasis. So in both Old World and New World, you can use pentoxifylline. I think we said that you want to look at this before you close and you didn't. You can use allopurinol, azoles, triazoles have been tried in combination with the antimonial compounds like sodium stibogluconate. Okay, so the ones I've told you about in the notes are the drugs you can remember. These are the ones that have been tried and they continue to be tried, right? Okay, so just have a look at this article. It gives you the main 3 drugs and other newer drugs. For example, in this article, it says other approaches for mucocutaneous leishmaniasis include pentamidine, nortephosin, imidazole, parmomycin sulfate, amphotericin B, and various lipid formulations of amphotericin B, such as the liposomal, the lipid complex, and the colloidal dispersion, along with combinations of pentoxifylline, allopurinol, and sulfur have been used. Okay. The post-Calazar lesions, 12-week course with miltefosine, we covered miltefosine, and amphotericin B over 4 months. In East Africa, post-Calazar dermal leishmaniasis is generally not treated, as majority of the cases resolve on their own within a year. However, patients with disfiguring severe disease, lesions can persist more than 6 months, and they can affect the eye. They can cause concomitant and anterior uveitis, or young children with oral lesions that interfere with feeding can be treated with SSG, and amphotericin. So this article, just have a look at it just to reinforce what you know. Okay? The emerging therapies, we have carbon dioxide laser administration and thermotherapy. Okay? So for cutaneous, if you want to try this laser administration and thermotherapy, these are for the cutaneous leishmaniasis. So thermotherapy and carbon dioxide laser directly on the skin to eliminate leishmania parasites. It involves applying external heat to the affected tissues, causing targeted damage to the parasite. Okay. So that we have the crystallization thermotherapy. It's a low-cost heat pack, safe, reliable, renewable conduction of heat. It has a cure rate of about 60%. The use of direct heat can accelerate healing of skin lesions. The carbon dioxide laser combined with cryotherapy and the stibogluconate compounds can accelerate healing time as well. So cryotherapy, you have a look at it. Again, for the cutaneous form, let's have a look at what they say there. With it's just called therapy. Okay. You can also have liquid nitrogen being added. We have tropical nitrate oxide derivatives. Nitric oxide can be used. Okay, so this article has very many new and emerging therapies which I told you to have a look at out of interest. So please have a look at this article. Now, let me show you the author. We said these are the authors: Shaiman Sunda et al. Okay, et al. Meaning other authors. He's the main author, and there are many other articles. Yeah? So let's view the PDF. And then I'll save it. And then if you need it, I can send to you, or you just Google it. See, the PDF is easier to read. Drugs we have covered. So do we have any questions on leishmania? The article will give you the benefits of having combined treatments. Okay, it gives you the, have a look at it, the immunotherapy for treating leishmania. It gives you, like this diagram shows you the live parasite, a stibogluconate compound as an interferon being used. You can add a new drug, you can add heat, and you can see the cure rate goes down the more the cure rate goes up, the more you add new drugs. Okay. So have a look at this article. You can't go through the whole article. and see the newer therapies. But at least the 3 drugs, surely you must know the 3 drugs. So this is a current 2024 article. It gives you all this. So please have a look at it. It's a very long article. We surely can go through at least 28 pages. Do you have any questions? Do you have to go through the whole article? So the expert opinion, at the end of the article, they give you the expert opinion. Leishmania is prevalent in 99 countries around the world. Treatment of various forms is still dependent on the stipogluconate compounds. And then it gives you, despite being associated with severe adverse effects like cardiotherapy, it's still the main drug. Okay? You can use liposomal amphotericin B and oral miltefosine are still being used, even after very many years. So it is an record that it took 75 to 85 years for liposomal amphotericin B, oral miltefosine, and PM to become available for anti-leishmania treatment. We're in dire need of new anti-leishmania therapies which are safe, affordable, can be stored at room temperature, oral, and have shorter regimens. Okay, so treatment of post-Kala-Azar leishmaniasis and or HIV viral visceral leishmaniasis co-infection. You can have a co-infection. Human reservoirs for leishmaniasis is very unsatisfactory. So you can see if the patient has leishmania and as well as HIV at the same time, the therapies are unsatisfactory. So for the treatment of post-Kala-Azar leishmania, double leishmania, 120 days of stibogluconate can be given together an infusion of amphotericin B 4 to 5 months recommended initially. However, these are extremely unsatisfactory, prolonged regimens, potentially toxic. And please remember the toxicity regimen we talked about in amphotericin B. Now, when miltefosine was approved, which is the oral drug in India, in small studies used for 12 weeks, it has assisted. However, contraception has to be practiced for 6 months. Okay? Contraception has to be practiced for 6 months. There are ocular complications when you add miltefosine. There's visual loss in about 1% of patients. All the rest are details. So they're just saying you need new drugs, but the 3 drugs, kindly have a look at it. So that is how you will look at an article when I give you an assignment, just for interest. Just for interest, look, the old drugs, okay, then the new drugs. If you don't even want to read the whole article, have a look at the abstract. What is the abstract? That is an executive summary, okay? It gives you the problems with the new drugs, the older drugs, long duration drug resistance, teratogenicity, high cost drug resistance. And then it tells you that according to the expert opinion, although that we have this sodium stibogluconate still being the backbone of therapy with all its adverse effects, newer things are being added like the cryotherapies, but newer drugs are needed to treat this condition. So do we have any question? So have a look at this article. It's an open access article. Shaima Sunda, just Google it. I will not question you on the details of it. This is just for interest to make everything sink home. And you can do the same for sleeping sickness. Are we together? Yes or no?
Yes.
Yeah. So have a look at it. And since you're the only one who talks, I hope the other students, even if you're not keeping up, today you're how many? Just say the classes can be repeated. I think your exams are in February. Notes I can send, I have no problem sending the notes. Could you be a bit more specific which notes you will require? And then we covered malaria. Okay, we covered malaria. But before we cover malaria, let us, I don't know if you can see my screen. I just want to again give you.
Excuse me.
Yes.
Yes, I have a question. Yes,
Yes.
based on the research paper that you've shared,
Mm.
I'll be more intrigued to maybe to learn the, let's say, if at all you can get real cases of trypanosomiasis within our locality, so that we appreciate the new emerging trends in treatment. Is that possible? Can we?
Treatment, yeah.
Yes.
Yes. Now, that one was for leishmaniasis. That was leishmaniasis.
Yes. Yes.
Now, you want new and imagine in local in Kenya.
Yes.
So you'll just go to, can you see my screen?
Yes, I can see your screen.
Okay. Leishmania. You can see my Google search, yeah?
Yes.
We are now going to center down on Kenya. So we have you can see treatment of leishmania, visceral leishmania. There's this CN Chunge. This guy actually used to have a clinic near in Hurlingham. He was the only specialist I knew. So there's this study. You can open it. There's one for 2025. I want to open treatment of visceral leishmaniasis in Kenya by Chunge in 1990. He's cited by 213 authors. So he actually had a clinic, this guy, stop calling him guy, he's a doctor. And he wrote this article. If you look at the abstract, this is in 1990. The treatment of leishmaniasis, as currently conducted in Kenya with sodium stibogluconate, is unsatisfactory as it is expensive. Resistance and relapse may occur. Major adverse effects have been reported. Currently, aminocidin, which is paromomycin sulfate. This is an aminoglycoside. We've covered this before, has shown good anti-leishmanial activity on its own, as well as synergism with pentavalent antimony administered concurrently. The present study was designed to assess the effectiveness of parenteral aminocidin alone or combined with sodium stibogluconate in visceral leishmania compared with stibogluconate alone. So he had a study, 53 patients were allocated to 3 regimens. Yeah. The presenting signs and symptoms of leishmania were those commonly seen with visceral form of the disease, particularly in Kenya. At termination, clinical cure rates achieved in all 53 with no difference between treatment groups. So he had 3 groups. He gave one stibogluconate alone. He gave stibogluconate plus amphotericin plus aminocidin or paromomycin. And then one he gave aminocidin alone or paromomycin alone. And according to him, he concludes that the treatment at the termination, clinical cure rates were achieved in all 53 patients with no difference between treatment groups. Spleen aspirates revealed best parasitological results in patients receiving a combination of treatment, 13% failures, partial cures and relapses, as opposed to 21% failures with aminocidin alone and 45% with stibogluconate alone. Treatment with aminocidin alone was the cheapest and safest. So that was in 1990, and he was the expert then. Now, let us look at this PLOS article in 2025. Yes? Can you see this?
Yes.
Yes. So, now this is a 2025 article. The author is Jane Mbui et al. Okay? It is May 2025. Assessment of decentralized model in improving treatment and care of visceral leishmania in Turkana, Kenya. Now, this article, if we let's look at the abstract. The abstract has 3 parts. Now, just remember, since I'm the same one who teaches research methodology, an abstract is an executive summary. So you don't want to read the whole article. You just want to see if it serves your purpose. The abstract has a background. It has the method used. It gives the results and the conclusion. So what did these authors do? They are concerned with visceral leishmaniasis, the one that's causing Kala-Azar. So it's a vector-borne so it's an introduction. She introduces it, or they introduce it as a vector-caused disease, yeah, by protozoa leishmania transmitted by the sandfly. Up to 60% of all visceral leishmania cases occur in East Africa. Given its ranking as a main cause of death among the parasitic infections worldwide, visceral leishmaniasis constitutes a serious global concern. So in Turkana, Kenya, the Foundation for Innovation New Diagnostics has undertaken significant work in supporting and decentralization of access to diagnosis and treatment, expanding from 6 facilities giving leishmania care in 2018 to 22 in 2022. This study sought to assess the decentralization of visceral leishmaniasis services in Turkana to inform policy at the country and the national levels. Remember that I've said 60% of all visceral leishmaniasis cases occur in East Africa. Let me just tell you that these are what we call the like forgotten diseases: leishmania, trypanosomiasis, river blindness. When HIV came, before HIV, this one, where all the research was going. After HIV came, everything went to HIV, and the silence came up. Now the methods, what did this person or this research team do? It was a mixed method, cross-sectional survey conducted in 4 selected health facilities in Turkana. So they used many methods. They did a cross-sectional survey. They used 4 sites in those years, November 2023, February 2024. It was a quantitative data involving data abstraction from records of visceral leishmaniasis patients between 2018 and 2022. So what that means, they just took quantitative data, they abstracted from the records of these patients who had visceral leishmaniasis. So from qualitative data, 13 in-depth interviews were conducted. So why is it a mixed method study, you asked? It's because they're doing interviews and they're also examining quantitative data from the files, data abstraction. So 13 deep in-depth interviews were conducted in these patients. 16 key informant interviews with health care workers and 7 key informants with health management team members were done. A key informant is a person who has a lot of knowledge on the disease, either a patient who has had the disease for very long, and here the medical workers, the healthcare workers, are the key informants for the study. They did a descriptive analysis of the quantitative data and a thematic analysis of the qualitative data. That just means they looked at the descriptive data, the quantitative data, and they described it. So quantitative data, they described that, descriptive analysis. Then for the interviews, they did thematic analysis. What does that mean? Is that they examined the interviews using themes. They took themes. Now you have to go into detail which themes they did. I'm not opening the paper. I'm just looking at this and I'm trying to summarize. Okay, so they did this thematic analysis on qualitative data to assess decentralization model. They want to improve this. So what did they find out? The results. The community had low knowledge of visceral leishmaniasis signs and symptoms. Remember, I'm telling you this is one of the forgotten diseases. The mean delay time since the onset of symptoms before seeking medical care was about 47 days. The long delay was mainly attributed to the long distance to health facilities, high cost for accessing treatment facilities. Majority of the patients sought traditional treatments before visiting healthcare facilities. Healthcare workers indicated that decentralization model has led to accurate diagnosis. So the more they opened the clinics, the more the treatment improved for the patient. So conclusion, there's low awareness of this disease. This is in 2024. They need to use more awareness campaigns to inform the community to be able to control. Now this study does not tell me, I have to go in detail. I don't think we have, this is not the course I want to teach now, but in short, I'm trying to look for the medication in a hurry. Diagnosis, treatment and follow-up. I want to see what drug was used currently there in Turkana. See, the treatment has changed. Okay, this study, I need to look at it maybe in detail. I just need to see what drug is available. And so far, I'm just saying that this combined therapies with PM and SSG. They must talk out of these drugs. So it's the same drugs they're using, they're not changed. Let us look at this. I hope you can still see my style, can you see my slides? Are they slides? Are you able to see?
Yes.
Yeah. So these are the drugs that they used. Ambisome, that is amphotericin B. Glucantin, I have to check. Paromomycin is the aminoglycoside. Sodium stipogluconate, miltefosine, then the kits. Yeah? And they're saying these medications are currently not in use in Kenya. They're saying these medications are currently not in use in Kenya. Why? I don't know. So the beginning balance, there were 13. Remaining balance, 13. They have stock up 39. The glucantin, 0. Paromomycin, remaining balance. So they appear to be using paromomycin. They appear to be using the sodium stipogluconate. The miltefosine is not available. The others are kits. The kits are not available. So the drugs remain the same. So the ambisome is amphotericin B liposomal. And you see it's not available. These are stock out. Eh? The drugs remain the same. Are we together? Are you able to see? So I don't know the question you're asking. Have I answered it? Or not?
You have answered it.
Let's check what glucantin is. It is just meglumine antimonate compound. So it is actually an antimonial compound. Okay, so that is how you look for the information you want, and you are able to get the information you need. And you can see we're using more or less the same drugs. And you see our issue is money. Our issue is money. But you've seen we have an issue that is Turkana, that is in northern Kenya. And then what happens? Let's look at the cost of glucantin injections. That's out of interest. So a 20 day course of miltefosine costs 16,000 Pakistani rupees. That's about 58 USD. So 1 USD now currently is at about 139. The managed cost there, 139 times 58. That is 8,602. 8,000. So that is the cost of treatment, about 8,000. So if you are from there, you can do these studies if you are interested. Are we clear?
Yes.
Now there's this malaria vaccine I wanted to cover today, and time is just moving. There's this malaria vaccine that was run it was introduced many years ago in Kenya. It was being tested, and now it became like a standard of care. I've seen as if it's given. So can you see my screen about malaria vaccine?
Yes, you can see your screen.
Yeah, so there is this malaria vaccine. It was tested. They started testing it in clinical trials for the past 10 years. And now they recommend 2 malaria vaccines are currently recommended for use in children living in moderate to high malaria transmission areas. And the one that in Western Kenya, around Victoria, and at the coast area, Kilifi, I've seen it. Current malaria vaccine reduce uncomplicated malaria by 40%, severe malaria by 30%, and it reduces all-cause mortality by 13%. This is why they said introduce it. Malaria vaccine should be delivered in conjunction with other control interventions, ITNs, and case management. So it means you have to use other methods. You have to clear the area, use those mosquito nets, clear all areas where that parasite can, the mosquito can live, etc. So malaria vaccines have been developed since 1960. I just want to look at this specific one. It was the RTS this vaccine, AS01 vaccine, and that WHO recommended is a GlaxoSmithKline vaccine. So the key findings, the vaccine introduction was feasible. So did I want to tell you about this vaccine? The way forward in this article, we will not. I wanted to tell you about mode of action. This is pharmacology, mode of action. And whenever you are doing this, of course, you have this AI overview. You can look at it in a hurry, but you need to, since you're in a scientific institution, you need to look at scientific articles. And you cannot rely so much. AI can guide you quickly, but for purposes of academia, kindly just keep to scientific scholarly articles. So, there are these vaccines, and they are telling us, this article tells us, there's this RTS and S and R21 vaccines currently in the market, and they're being used here in Kenya, I can tell you. So the Plasmodium parasite causes malaria. Hope you looked at the life cycle, we said. And we said the Plasmodium falciparum is the one which is deadly. Then we have the Anopheles mosquito. So these vaccines trigger production of antibodies that block sporocytes from infecting liver cells. Can you write that? Are you going to write that, or you're going to be... I will put this as one of the questions. So you must know that they trigger production of antibodies. And we need to do the cut next week. That blocks sporocytes. So when can we have the cut? From infecting liver cells. And remember, we covered the life cycle, and I showed you at what point liver cells are infected, which drugs are gametocytic, sporocytic, and all that. And then those that break through are targeted by T cells, which also are activated by the vaccine. So you can see there are two modes of action. Are we together?
Yes, we are together.
Yeah. So just know this because this drug is in use. So can you write that? And I forget to send notes, you say you've never heard of it. Or you can Google this. But I'm telling you, I'll put this question. I'll put it in the exam. So can you write it? And this is a simplified explanation, but for your level, it will do. So do not say you have gotten 0 in the exam and you're calling me. Please do not call me. I've already given you one question. I'm going to put it there. How does it work? They trigger production of antibodies that block sporocytes from infecting liver cells. Then the sporocytes that manage to break through are targeted by T cells, which also activated by the vaccines. So I hope you have written that. And here we had the life cycle. We have the mosquito taking the sporocytes to the liver. That is the first target. Anything that goes through, we said the vaccine will actually activate T cells to destroy the parasites that have gotten through. So from after the sporocytes, we form merozoites. Yeah? Merozoites, then they form gametocytes. Gametocytes can be picked by the mosquito to then start the sexual stage, which occurs in the mosquito. The mosquito then transmits again the sporozoites. So this article, it is Gavi. It's a Gavi article. Have a look at it or Google it. You want that diagram for quick memory. Okay, you know what I mean? So malaria, the cycle begins when highly mobile sporozoites are transferred from the mosquito to the human. So the mosquito transfers it. The female Anopheles mosquito, through a blood meal, transfers the sporozoites to the man, the human. The sporozoites travel to the liver, where they infect liver cells, multiply and mature to merozoites. And these merozoites, we said, are the ones that are causing the signs and symptoms. The current malaria vaccines are designed to block infection at this stage before the parasite grows out of control. The merozoites leave the liver, infect red blood cells where they continue to grow and multiply. So remember, the merozoites are what are causing signs and symptoms. Some merozoites develop into the sexual forms, the gametocytes. And then these ones are then picked through a blood meal. The sexual stage occurs inside the mosquito. We have the gametocytes, and those then form the sporocytes. And this migrate to the mosquito salivary glands, where again the infection is passed on. So once inside the body, the parasites remove from tissue, changing. Look at the picture. It is a sporocyte stage of the life cycle that both the RTS and the R21 matrix M vaccines target. So the sporocyte stage is targeted by the vaccine, catching the parasite before it has time to grow out of control. So both vaccines target a protein form in the surface of sporocyte called circumsporocyte, which helps the sporocytes to travel and invade the liver cells. So write that, or don't write it, don't call me. So we are saying the vaccines, can you write it? Target a protein. Are you writing, or you're just with your phone? Finding out how people have eaten Christmas. They target a protein on the surface of sporozoites. We have seen where the sporozoites are. Called circumsporozoite protein. Circumsporozoite protein. That help? That help sporozoites invade liver cells. The vaccine, the RTS and S vaccine, contain fragments of the circumsporozoite protein linked to a protein from the hepatitis B vaccine that naturally assembles into a virus-like particle structure that look like viruses, yet they are completely harmless. Linking the circumsporozoite prostate in this way helps to alert the immune system to invoke a stronger vaccine. So they have linked this protein to the hepatitis, a part of a protein from hepatitis B vaccine, that naturally assembles into virus-like particles. And this helps the body to recognize and kick up the immune system. Okay, so the R21 vaccine contains fragments of the SPS linked to the hepatitis B protein, but the manufacturing process differs, resulting in more of these CSP proteins becoming attached to each virus-like particle. The vaccines also delivered along different adjuvants. Now, vaccines also have other things in them apart from, for example, the antibodies, for the antigens, sorry. They also have other things called adjuvants. They're just substances that boost further immune system's response to the disease. So both vaccines trigger the production of antibodies that block sporozoites from infecting other cells. Are we together? So those that manage to break through are targeted by the cells. Why? Because they have adjuvants. So they're saying that both, there's no difference in efficacy between both. WHO has granted pre-qualification status to both vaccines, final vetting to ensure the vaccines are used in immunization programs are safe and effective. And I say that the choice of product should be based on programmatic characteristics, vaccine supply, vaccine affordability. So just know that on top of all the drugs we covered in malaria, we also have this one for malaria vaccine. Do we have any questions? So am I to assume you are hearing, understanding? Any questions? So I can see you're about 40 something today. Do we have any questions on anything to do with this unit? Have you finished the assignment? Wait, did you put the assignment in the pigeon there, class today? Did I pick it? I can't remember.
We collected the assignment and the takeaway cards.
Or you put them in the office. So
Yeah.
you have a paper 2. A paper 2 is 2 questions. I'm just trying to check. 2 questions, 2 essay questions, 20 marks each. Then you have a paper 1. And paper 1, I have to set, what is this? I have to set 20 questions, multiple choice questions, and 2 short answer questions. And then in the course outline, can I cover anything? So the day we meet for our physical cut, which should be next week on Tuesday, we meet at 7:30 for the cut. You should be able to, according to this course outline for the exam, describe the modes of action, pharmacokinetics, pharmacodynamics, side effects, drug interactions, anti-malaria treatment, antifungal treatment, anti-helmintic treatment. The course is finished.
Excuse me.
Yes.
Can we do the cut on the next week but one, because we have another cut on Tuesday next week.
But it's not my cut. How is that one my problem? Huh? Because now the day for the exam will be examined on anything. Okay, you can do the cut next week but one. But are we meeting next week then? Are we?
I don't think so, because we are through with the units.
You're done with the unit. So hoping that you've done with the unit, you will also pass the unit. Okay, so being done is okay. It's good. We are done. And I think we have not covered any cases. Are you going to the ward?
Yes, in clinical pharmacy.
Are you picking any patient with malaria? With fungal infections? With anti-helmintic? Have you seen any patient with such a thing?
Not yet. Maybe next week, because we have ward rounds next week.
Oh, you have never gone. You're going to be going this time.
Yeah, we went once, then we are going again next week.
Okay, so can you just be on the lookout, not for me, but for you, just check what is happening with a malaria patient. What is happening with a patient who has got a fungal infection? What is happening with any patient who has any parasites in the body? Remember, the patient does not come with malaria. Yes, they can come with malaria, but they come with malaria, they have hypertension. They come with malaria, they are pregnant. They are on anti-helmintics, they are diabetic. Yeah, so it's very interesting to see what is happening in the world. Will you at least get some cases for to have a look at in the class? Did Faith drop out of this class? Or she's still in it? Are you still there, Faith?
Yes.
So I'm just saying many of these things in pharmacy or in any unit, If you do not see them, when you see them, when you graduate, when you're one who is sick or your family member is sick, you'll find you're even losing a patient from just malaria because you did not see how it presents. You are not able to look at the drugs properly because a textbook drug is not the same as. So you have to make the course practical for yourself. That is why the clinical pharmacy comes in. So have a look because by the time a patient is admitted, they have complicated malaria. So have a look. What is the patient presenting? And which medications are they being given? How is the malaria being tested for in that hospital you are going? Pick a level 5. What are the drugs currently in use? Are we clear? So if you find any patient for discussion, kindly just post the patient or say you want to present the patient online. In fact, because you have January, I want you to divide yourself into 3 groups. One, you look for a patient with malaria because malaria is very common. Another one, you look for a patient with a fungal infection. Yeah. Another one, you present a patient with who is having on any antiemetic drug. So can we say that that can contribute 5% of your marks at the end of the unit? Faith.
Yes.
Yeah. So you divide the class in 3 groups. You will go and look for that one patient. You divide one for malaria. Why? It's very common. Any other disease we have covered, either amoebiasis, another group. If you find a patient is sleeping sickness or leishmania, they may be there. We used to have these drugs before in Thika level 5 many years ago, but the patients weren't coming. Have a look, pick one. So just have 3 groups, and then you do a presentation, hopefully before the unit, and then we allocate 5 marks to it. Otherwise, you will graduate, yes, but you've not seen the condition. Are we together?
Yes.
So next week, but one is the cat.
Yes.
Okay. Any questions? And mind you, in the medical ward, you'll find so many of these patients. You just want to see amphotericin B in action. Huh? You want to see things like metronidazole, very common. Paromomycin, very common. Which other drug is the patient on? Because now the patient has come with 2 conditions. Are there any drug-drug interactions occurring? Are there any, why will you give the patient specific instruction? Take after food, take with food. Are we clear? Or no?
Yes, you are clear.
Yeah. Then we have finished the unit, unless you have any questions. Also, have a look at current medications for trichomoniasis, just because can you see my clinical care for human African trichomoniasis treatment? Are you able to see my screen?
No, it's
Yes.
still on.
You can see it?
Yes, a mode of action of atobacol.
No. Clinical care for human. Let me connect it again.
No.
Let me connect it. The malaria medications, you have to have a look at what's happening. What is in the market? Just show an interest. Why are we combining this one plus that one? Sorry, I lost my internet. Are you able to see the screen?
No.
Let's try again. Here. Can you see?
Yes.
So the journal here is Lancet Infectious Diseases, February 2025. I had told you to look at this article. Now, here's the summary, the abstract. This is what I was telling you. These ignored and neglected diseases, and they became neglected after HIV. So WHO revised its Rhodiensis human African trypanosomiasis treatment guidelines on the basis of an independent systemic literature review following the GRADE methodology. We'll look at that GRADE later. So this review reports on the decision-making process and the summaries and the new recommendations and their potential implications for healthcare professionals and policymakers. Due to data scarcity, all recommendations are conditional based on very low certainty of evidence. So they're saying this drug, fexinidazole, it replaces suramine and melarsoprol as first line individuals 60 years and older, body weight of 20 kg or more. Fexinidazole is effective in both stages of rhodiensis human African trichomoniasis. A lumbar puncture for staging is no longer required. In setting in which first choice drugs are not ever available, immediate interim treatment with pendamidine is suggested. Introduction of oral fexinidazole presents represents an advancement in management of rhodiensis human African trypanosomiasis, considering it's a life-threatening disease. Considering life-threatening adverse reactions to melarsoprol. Okay, so we have these drugs, fexinidazole. So I want you to go and check. Don't give me. Check the mode of action of fexinidazole. Okay, so you can see this is a lancet. A lancet is one of those so-called backbones of medicine. Found this lancet. So you have fexinidazole. That is the WHO guideline. Okay, fexinidazole to replace suramine and melarsoprol. Okay, so kind medication for trichomoniasis. Now we type in Kenya. Of course, you will see we still have the whole WHO Lancet article on fexinidazole. Okay. And then we see what is happening in Kenya. A closer here, the CDC guideline. I think we're following the CDC guideline. And you will see treatment for this African trypanosomiasis. And remember, we said ours is rhodiensis. Gabiensis is in West Africa. But maybe you can also have traveled from West Africa, or you go from East African to West Africa, so you can get any of the diseases. So treatment, first stage of T, brucei gabiensis, pentamidine. Fexinidazole is now available. Remember, children above 6 years weighing over 20 kgs. Now let me give you the second leakage. I'm going to bring the mode of action of this fexnidazole in the exam. Okay. Treatment during the second stage. The second stage is when you have CNS involvement, nifurtimox, enflonithin, or fexnidazole in children or in patients over 6 years old weighing over 20 kg. Treatment of TB rhodiensis. We have, now this is the one in Kenya, to include fexnidazole as first-line treatment, recommended in first and second stage of human African trichomoniasis in children greater than 6 years, over in adults and children over 6 years and over 20 kg. For children less than 6 years or weighing less than 20 kg, suramine is the first choice. Suramine is the first choice. The question is, do we cover these medications? Before you tell me you've never heard of suramine, you've never heard of, I don't know what you've never heard of, inflonithin, the modes of action. Okay, I think we covered them. Did we cover them, true or false? Nifurtimox. Did we cover pentamidine? Did we cover?
You gave us assignment of
Yes.
15 marks
Mm-hmm.
to discuss all the mode of action of all the hemoflagellates, of all the drugs for hemoflagellates.
Yes, so you have,
which we have not submitted.
why have you not submitted? They've come from Christmas.
You said you will submit when you start the new year. So
Okay.
You can tell us when we can submit.
Can you submit for me that assignment on the day of the cut, which is next year? Not next year, next week, but one. You're saying not next Tuesday, the other Tuesday. Can you submit at that time?
It's okay.
Yeah, submit that. So, we said suramine, pentamidine, early disease. And now suramine, you can use it below 6 years, below 20 years. But of course, since this drug, fexnidazole, may not be available, I assure you getting it is very difficult, then you will stay with the normal drugs that we have talked about, eflonithin, melarsoprol. Okay? I hope we are clear. So, for example, eflonithin, we said is an irreversible, or we didn't say it is an irreversible catalytic suicide inhibitor of ornithine decarboxylase. We've covered this drug in a previous unit. Melarsoprol, we said, it is a prodrug, it's metabolized to malacine oxide, and then this malacine oxide, it reacts with the sulfur hydrolyl groups and it activates enzymes in the parasite. Okay? Suramine, we said, we've covered suramine before, we said in onchocercosis. Okay? We had said the mode of action is unknown, but it can be proposed. Okay? So, for the exam, I'll definitely ask you, give me the mode of action of fexnidazole. Okay? So, have a look at that. So, consultation with an expert. Consultation with a subject matter expert, a CDC's advice to discuss treatment options for patients with TB rhodiensis, TB gabiensis infection. There is no test of cure for it. Yeah? There is no test of cure after you give the drug. After treatment, patients should be closely followed for 24 months, monitored for relapse. Recurrence of symptoms will require examination of body fluids, including CSF, to detect the trypanosomes. So this is the CDC guidelines. I'm sure is what we use. The TC brucellosis gambiensis first stage pentamidine. Fexnidazole. But pentamidine is the one. It remains because as this other one come, nifurtimox, enflonithin, gabiensis, second stage. Second stage meaning what? You have CNS involved. Okay? So look at this guideline. Okay. Look at the adverse effects of this medication, and then you'll be okay. Now, see you next week, part 1. Do you have any questions? Do you have any questions? So have a look. Whenever you can be asked even by the external examiner about the parasite, when it is not the parasite, the vector, you can't just sit there. You don't know anything about mosquito nets. You don't know anything about insecticides. You can surely have an intelligent guess about what's happening. Okay, so have a look at what is online, and then you'll be able to inform yourself, especially if you're from these areas. And if you're from an area where a disease is rare, definitely for your 4th year, 5th year project, you can cover this disease. Okay? So if there are no other questions, I think we can call it a term. But when we meet for the cat, I can also have some patients we can look at if you remind me. Look at some patients, the reasons we combine some medications, etc. So see you next week, part 1.